Good morning. I'm John O'Brien, the Deputy Assistant Secretary for Health Policy in the Office of the Assistant Secretary for Planning and Evaluation. And on behalf of Secretary Price, I'd like to welcome all of you to this meeting of the Physician-Focused Payment Model Technical Advisory Committee. As a physician himself, Dr. Price knows that providers have a unique perspective to share on how healthcare can be transformed to lower costs while increasing quality. As you heard at the last meeting, he's encouraged by the number and breadth of innovative ideas coming to PTAC for consideration. And the Secretary is very appreciative of the thoughtful work that PTAC has done thus far to evaluate the ideas that have come forward, and he values the PTAC as one way for bringing physicians and their best ideas for healthcare delivery and payment forward for consideration. HHS is looking forward to reviewing PTAC's recommendations for the 3 proposals now before the committee. And I know it's going to be a busy couple days and you have a lot on your plate, so I'll let you get to work with the thanks of Secretary Price and myself. Now I'd like to turn the meeting over to Dr. Jeff Baylett, PTAC Chair, and Elizabeth Mitchell, the Vice Chair.
Thank you, John. Good morning, everyone, and welcome to this meeting of the Physician-Focused Payment Model Technical Advisory Committee, or PTAC. We're delighted to have you all here. In addition to the members of the public here in person, we have participants watching the live stream and listening on the phone. As you know, this is PTAC's second meeting that will include deliberations and voting on proposals, Medicare physician-focused payment models submitted by members of the public. We would like to thank all of you for your interest in today's meeting. In particular, thank you to the stakeholders who have submitted models, especially those here today. Your hard work and dedication to the payment reform process is truly appreciated. PTAC has been active since our last public meeting in April. Since that meeting, we have submitted recommendations and comments on 3 physician-focused payment model proposals to the Secretary of Health and Human Services that were voted on at the April meeting. We have written a letter to the Secretary outlining key lessons learned from our work to date that Dr. Price is aware of, our progress, and our thoughts on physician-focused payment models. You can find that letter on the ASPE PTAC website. We have updated the proposal submission instructions to make the process for submitting a proposal even clearer and to accommodate changes to how the proposal review teams and PTAC conduct their work. The updated proposal submission instructions can also be found on the ASPE PTAC website. PTAC has updated our bylaws to reflect an even stronger commitment to transparency and disclosures of potential conflicts of interest. And of course, we have been very busy reviewing and evaluating physician-focused payment model proposals from the public. I'm pleased to report that interest in submitting physician-focused payment model proposals to PTAC continues. To date, we have received 15 full proposals and an additional 16 letters of intent to submit a proposal. The proposals are from a wide variety of specialties and practice sizes, and they propose a variety of payment model types. For example, a dozen different specialties and subspecialties are represented in the letters of intent we have received. There is interest in physician-focused payment models by both small and large group practices. Small physician groups have submitted 6 letters of intent and 3 proposals, and large group practices have submitted 4 letters of intent and 1 full proposal has been received. Bundled payments and care management models comprise the majority of the proposals to date, but we have also received proposals or letters of intent that relate to capitated payment and other payment models. We are pleased that we have so much interest from clinical stakeholders in proposing physician-focused payment models, and we're fully engaged to ensure proposals are reviewed expeditiously and comprehensively. We are already looking ahead to our next public meeting, which will be held here in the Great Hall of the Humphrey Building on December 18th and 19th. One simple reminder, to the extent that questions may arise as we consider your proposal, please reach out to staff through the PTAC.gov mailbox. The staff will work with me as chair and Elizabeth Mitchell, the vice chair, to answer your questions. We have established this process in the interest of consistency in responding to submitters and members of the public and appreciate everyone's cooperation in using it. Today, we will be deliberating on 2 proposals, and tomorrow we will deliberate on 1. To remind the public, the order of activities for each proposal is as follows. First, PTAC members will make disclosures of potential conflict of interest and announcements of any committee members not voting on a particular proposal. Second, discussion of each proposal will begin with presentations from our preliminary review teams, or PRTs. Following the PRT's presentation and some initial questions from PTAC committee members, the committee looks forward to hearing comments from the proposal, submitter, and then the public. The committee will then deliberate on the proposal. As deliberations conclude, I will ask the committee whether they are ready to vote on the proposal. If the committee is ready to vote, each committee member will vote electronically on whether the proposal meets each of the Secretary's 10 criteria. The last vote will be an overall recommendation to the Secretary of Health and Human Services. And finally, I will ask PTAC members to provide any specific guidance to ASPE staff on key comments they would like to include in the report to the Secretary. A few reminders as we begin discussion of the first proposal. PRT reports are from 3 PTAC members to the full PTAC and do not represent the consensus or position of PTAC. PRT reports are not binding. The full PTAC may reach different conclusions from that contained in the PRT report. And finally, the PRT report is not a report to the Secretary of Health and Human Services. PTAC will write a new report that reflects the deliberations and decisions of the full PTAC, which will then be sent to the Secretary. It is our job to provide the best possible recommendations to the Secretary, and I have every expectation that our discussions over the next few days will accomplish this goal. Let us all introduce ourselves. I'd like to introduce Elizabeth Mitchell. She's the PTAC's Vice Chair. I'll let Elizabeth start.
Elizabeth Mitchell, President and CEO of Network for Regional Healthcare Improvement.
Lynn Nichols, Direct the Center of Health Policy Research and Ethics at George Mason University.
Hi, Kavita Patel. I'm at Johns Hopkins as an internal medicine physician and the Brookings Institution.
I'm Bob Berenson. I'm an Institute Fellow at the Urban Institute.
I'm Rhonda Meadows. I'm a family physician. I'm the Executive Vice President for Population Health at Providence St. Joseph Health.
Tim Ferris, Primary Care Internal Medicine and CEO of the Mass General Physicians Organization at Partners Healthcare.
Catherine Sabra. I'm a Presidential Management Fellow and the Assistant Secretary for Planning and Evaluation working on PTAC.
I'm Harold Miller. I'm the President and CEO of the Center for Healthcare Quality and Payment Reform.
Paul Casal, a cardiologist, and lead the ACO at Weill Cornell, Columbia, New York Presbyterian.
I'm Bruce Steinwald, a health economist with a small consulting practice in Northwest Washington and lots of government service in the past, including in this building.
I'm Ann Page. I'm staff in ASPE to this PTAC committee and also the designated federal officer for the PTAC, which is an advisory committee under the Federal Advisory Committee Act.
And I'm Mary Ellen Stallman, ASPE staff and the staff lead for the PTAC support team.
And I'm Jeff Baylett, Executive Vice President of Healthcare Quality and Affordability with Blue Shield of California. And I'm also the chair of this committee. I'd like to thank my colleagues for all of the good work and the countless hours and the careful and thoughtful expert review of these proposals as they've come through the committee. Again, I want to personally thank everyone for their work. And we're going to go ahead and get started. The first proposal this morning we will discuss is the Icahn School of Medicine at Mount Sinai and is entitled Hospital at Home Plus, Provider-Focused Payment Model. So the PTAC members, let's start the process by having each of us disclose any potential conflicts of interest on this proposal. So I'm going to start, and we'll go around the room. So with respect to the Mount Sinai Hospital at Home proposal, I have no conflicts.
Nothing to disclose.
Nothing to disclose?
Nothing to disclose.
I have something to disclose. I am a graduate of Mount Sinai School of Medicine and occasionally have made charitable contributions, very occasionally. I have no other relationship to Mount Sinai.
I have nothing to disclose.
I have something to disclose. I know some of the submitters through presentations at national and international meetings that we have both attended. As a result of hearing Dr. Al-Su speak at an international meeting, I organized for him to visit my institution and present the hospital at home concept at my institution.
I have no conflicts to disclose.
Nothing to disclose.
Nothing to disclose.
All right, we've previously reviewed the disclosures, and we've concluded that nothing in the disclosure should preclude any PTAC member from full participation in deliberations and voting on this proposal. We have 10 members voting on the proposal today. And now I'd like to turn the microphone over to the preliminary review team for this proposal. Harold Miller is going to present the PRT's findings to the full PTAC as the PRT lead. Harold?
Thank you, Jeff. So I am presenting on behalf of my colleagues on the PRT, Rhonda Meadows and Len Nichols. Also, we had excellent staff support from Catherine Sapra, who is sitting to my right, and will make sure I don't screw up anything during the process of this. The presentation that I'll go through basically will cover our composition and role, an overview of the proposal, at least as we understand it, the summary that the PRT's review, the key issues that we identified, and then the evaluation that we did of the proposal based on each of the Secretary's criteria. So just as a review for everyone of the process, we, the 3 members of the PRT, were assigned by the chair and the vice chair. At least one of us, namely Rhonda, is a physician, and one of us, namely me, is assigned to serve as the team lead. We go through a process of reviewing the proposal, of identifying additional information that we need from the submitter, and requesting that information. I want to commend the submitter for, first of all, giving us a very well thought out and prepared proposal, and also giving us very detailed, clear, concise, and thoughtful answers to all of our many questions. We asked a lot of questions, and also had a in-person discussion with them on the phone, which was very helpful. After doing all that and some additional analysis that we did, looking at the literature, et cetera, we prepared our report to the PTAC, which has been posted. Just also to comment on top of what Jeff said earlier, the only people on the PTAC who have discussed the proposal at all before today are the 3 of us. There has been no discussion by the full PTAC, so this will be the first time for everybody else on the PTAC. And our report is obviously, as Jeff said, not binding. So let me describe the proposal, at least as we understand it, and then the submitter can clarify if there's anything that I state that's wrong. This proposal is essentially a payment model designed to enable the delivery of hospital-level services at home for patients who would otherwise be hospitalized. And the goal is to try to reduce costs by delivering services in the home rather than the hospital, but also to improve quality by reducing complications that patients can often experience when they are in the hospital. As well as to improve the whole transition process after hospitalization, because the patient actually is not in the hospital. They are at home during the acute phase as well as the post-acute phase. So this model is targeted specifically to patients who could be hospitalized and would be eligible for hospitalization, but could be taken care of at home, which is obviously not everyone who would potentially come to the hospital. The way the model was structured was that it identifies a series of diagnoses which are expected to be patients who could be potentially taken care of at home, but then there are additional clinical characteristics of the patients beyond their diagnosis, which would suggest whether or not they are appropriate for home care, and also whether they have the appropriate home environment to enable home care to be delivered. The services that the patients receive are divided into two phases that the payment model supports. One is an acute phase, which is technically equivalent to what the patient would have been hospitalized for, and then a post-acute phase. The proposal refers to the post-acute phase as a transition services. We found that slightly confusing only because the term transition is often used by many people today to simply reflect a short period of time that occurs after discharge of the hospital. But what the proposal is actually proposing to support is 30 days of care for the patient after the conclusion of their acute phase. So we have tended to refer to it as more of a post-acute period rather than simply a transition period. All of that is basically home-based care for the patient, although if the patient needs an actual inpatient hospital admission, they can be what is referred to by the submitter as escalated to an inpatient admission. The payment model for this has two components. One is essentially what you could call a bundled payment, a fixed amount of money that would come to the entity that delivers these services to support all of the services that they deliver during the acute and the post-acute phase of this care. The payment amount would be based on a calculation that would be based on the DRG, the diagnosis-related group that would have been calculated for that patient under the Medicare DRG grouper, but also an estimate of the physician services that would have been delivered in the hospital based on the average for that DRG. Because under the current Medicare payment system, the hospital and the physicians are paid separately, and the physicians are paid on a per visit or per procedure basis. So the idea would be to create essentially a super DRG payment that would be the combination of what the hospital would have been paid and what the physicians would have been paid, and then discounting that amount by 5%. That would essentially pay for the services that were being delivered in the acute and the post-acute phase. Then there is a performance-based payment that looks at the total amount of spending that occurred during that period, during the acute and the post-acute phase, because not everything that the patient received would necessarily be covered by the payment that the entity participating in this would get. So if the patient, for example, went to see a specialist, the specialist would be billing separately for that. If they needed some other kind of billable service, they would be able, the provider for that would bill for that. So the second part of this payment essentially adds up all of the services that the patient did receive and that were billed to Medicare, and compares that to a benchmark amount as to what would have been expected that would have been spent on the patient with these particular characteristics, with a 3% discount on that. And then there is a shared savings, shared risk model attached to that. So if that spending is below what would have been expected, then some of that savings comes back to the entity. If that spending was higher than would have been expected, the entity has to pay that increase back to Medicare. So that's what's referred to as the target price and how that would be calculated. And those savings and return payments are capped at 10% of the target price. And there would be an adjustment to that shared savings, shared loss payment based on the quality of care that would be delivered based on a series of quality measures as part of the payment model, which will become relevant to some of our later discussion. So in our review of this, we went through each of the 10 criteria that are specified in regulation by the Secretary for our review. And I will review each of those individually in a few minutes, but as a summary, we, as a PRT, unanimously agreed on all of the ratings that you see on the screen. We felt that the proposed physician-focused payment model met the criteria in all but one case. The only criterion that we felt did not, the only aspect of the proposal we felt that did not meet one of the criteria was respect to patient safety. And so we unanimously agreed that the proposal as written did not meet that criterion. So as a summary of the key issues that we identified, this is sort of an overview, and then I'll talk about this with respect to each of the criteria. We felt that this filled an important gap in the portfolio of Medicare payments because there really is very little that supports home care for patients and essentially nothing that is designed to support hospital-level care in the home for patients who would otherwise be hospitalized. It is specifically designed to improve quality and to reduce costs. It is focused on avoiding essentially the undesirable things that can potentially happen to patients when they are hospitalized, and to avoid the transition process that occurs when a patient has to be hospitalized and then sent back home because they are essentially at home through that entire period of time. It is a bundled payment for both the acute and the post-acute phase, so at least during that period of time, there is no concern about shifting costs between one period and another, and there is a measure of the total spending that occurs, so there is no concern about shifting costs between what the entity is paid for versus what is paid for separately by Medicare. And we felt that this could potentially work well for other payers, certainly for the Medicare population for Medicare Advantage plans, but also potentially for commercial payers because many patients who are younger than 65 are hospitalized and could potentially be cared for at home with the appropriate kind of support. The weaknesses that we saw at the broadest level were that this service that the payment model would support requires a certain minimum capacity in terms of physicians, nurses, et cetera, to be able to deliver the services. Yet the payment model is a per patient payment. So if you don't have enough per patient payments to be able to cover the costs of that minimum fixed costs of the service, then you could not sustain the service. So the concern was that that potentially leads to some incentives, if you will, to try to boost the number of patients who are included in the model in order to get enough per patient patients to be able to cover the costs. And that could go in two directions. One is that it could mean that some patients who really weren't appropriate to be cared for at home could be cared for at home in order to increase the volume. It could also be the case that some patients who would not really have been hospitalized in the first place could be put into this program, who could certainly be cared for at home but wouldn't have been hospitalized. Second concern is that the payments, because they are based on hospital-level payments and current spending on post-acute care, may not really match the actual costs of delivering the care. I described one reason why the costs might be higher than the payments. The other potential is that other examples of this kind of a program being implemented around the world have shown that potentially very significant savings can be achieved because patients could be cared for in many cases at much lower costs. So the question is whether or not the payments really match the appropriate costs. We felt that there was a weak link between quality and payment. Although there are quality measures specified in the application, they are tied to the shared savings, shared loss payments. That is very similar to what is done in the Medicare Shared Savings Program for ACOs, but it is done there because essentially there is no payment for an ACO other than the shared savings, shared loss payment. Here, there is a payment to the entity delivering the services. So there is a different payment that could be modified based on quality, and we felt that that should be considered. We felt that while there are quality measures included, that they were not sufficiently comprehensive to really address the concern that patients who need hospital-level care are being cared at home, and there is no medical professional there at all times. One of the concerns that was raised is that adverse events with a population like this occur, but they occur at fairly small rates, and so the concern about having a small rate measure affecting payment was a concern. So we noted that we thought that those things should be at least monitored, if not affecting payment. So we felt additional mechanisms were needed both for adjusting payment based on quality and also for monitoring safety. So I'm going to go through quickly each of the individual criteria and just explain why we rated it as we rated it. So the first criterion relates to the scope of the proposed PFPM, and the regulatory statement is that this proposal needs to either directly address an issue in payment policy that broadens and expands the CMS APM portfolio, alternative payment model portfolio, or to include APM entities, the entities that would be receiving the payments, whose opportunities to participate in alternative payment models have been limited. And as I stated, we felt as the PRT, the three members of the PRT felt that it met that criterion, and we felt that was true unanimously because we felt that this really did fill a gap by covering home-based acute services, which no other CMS model really does. There are other models that do sort of pieces of that for certain kinds of patients, but they are mostly oriented at avoiding hospitalizations, not for avoiding people from having to go to the hospital and needing a hospitalization in the first place, rather than taking people who need a hospitalization, but delivering that in the home. As I said, a concern is that there's a minimum number of patients who are needed to make the program viable. We did some analysis based on what the applicant estimated was a minimum number of patients to participate. The applicant estimated at least 200 patients would need to participate in order to be able to make the model viable. And we looked at some estimates of how many patients were likely to meet those characteristics, and concluded that probably in the vast majority of rural areas there would not be enough patients to meet that minimum, that there would be in urban areas, but even in many urban areas there would not be. That did not to us mean that this was an undesirable model. It just meant that the ability to be able to deliver it cost effectively under this approach would be challenging in smaller areas. But who knows what innovation and entrepreneurship might be able to deal with. So we felt that at least initially this was likely to be something that larger organizations would do. Doesn't mean that down the road smaller organizations wouldn't, but more likely applicable to larger communities and larger organizations. But we did feel that overall this was filling a gap. Second criterion related to quality and costs. There are a variety of studies. The United States is a bit behind on this. There are other countries that have done this in a major way. The state of Victoria in Australia has a major hospital-at-home program, and someone there wrote an article a number of years ago describing the 500-bed hospital that was never built because of the number of patients who are participating in this program. So it does have some experience and evaluation showing that it improves quality and reduce costs. And as I mentioned earlier, there are some features of the model that really ensure that costs are not being shifted and that there are savings. But we do think that there are some safety risks, that there are some concerns about the minimum volume of patients. We were somewhat concerned about the cost to whom. It would be designed to basically pay less than Medicare would pay or spend today. But that doesn't necessarily mean that it would not have some cost implications for a hospital. If you are taking some patients out of the hospital and putting them into the community and the hospital is no longer paid for those patients, then the hospital has fewer revenues to cover its costs. And it is possible, not clear at the moment, but some studies have shown this, that you're essentially taking out of the hospital patients who would otherwise have lower than average costs in the hospital, leaving the hospital with a higher than average cost patient population, but with the same DRG payment remaining. So there would be some concerns about the potential implications that this would have for hospitals and potentially leading to, if this was implemented broadly, an increase in DRG rates to be able to cover that. We thought that there are some concerns about the way the savings calculation was done because you cannot necessarily assume that these patients would have had the same post-acute care costs as the average patient being discharged from the hospital. But we felt that those issues, those specific issues here in terms of benchmarking and price, et cetera, could be dealt with simply by adjusting the parameters of the model, and that in fact it's no different in that regard than many other payment models that get introduced and that you have to adjust over time. The Medicare inpatient prospective payment system, for example, when it first created DRGs, ended up with DRGs that were priced higher than what hospitals ended up having to actually spend on care after they changed the level of care. So the DRG rates were adjusted, and the same thing could happen in a model like this. It would simply be, there would need to be recognition that that kind of adjustment would need to be made. Third criterion, with respect to the payment methodology, we thought that the applicant did an excellent job of describing the methodology in detail and trying to address a lot of the potential issues associated with cost shifting, how the calculations would be made, et cetera. As I mentioned, there would need to be some further adjustments to all of that, and that there needed to be some adjustments for quality. The applicant indicated that they were willing to consider adjustments to the basic payment based on quality, but I think preferred to have it adjusted based on the shared savings, shared losses. We felt fairly strongly that the basic payment needed to be adjusted because, in fact, if there are no shared savings or shared losses, then there is no adjustment for quality, and we felt that there should be some way of holding an entity accountable for quality regardless of whether there were savings and costs. But we felt that the methodology as specified was sufficient to merit meeting the criterion, and that the adjustments that could be made were fairly easy to do. I would note that the applicant in the proposal really proposed three different things. They proposed something called hospital at home, observation at home, and palliative care at home. We, I think, probably succumbed to complexity a bit and concluded that trying to deal with three different payment models at the same time was a bit much, because there were nuances associated with each of them that would be different, and that in some sense each of the models would really need to be fully specified rather than saying it would be kind of like hospital at home, but we'd have the following changes. And so we really felt that in the absence of having a clearly specified model for each of those, that we simply did not feel that we could review the payment methodology, so we essentially put those two pieces aside. We did not feel, and the applicant confirmed, that having those two components was essential to implementing either the hospital at home program or implementing the hospital at home payment methodology. So we basically treated that, the hospital at home component, as what we felt this proposal was, and our recommendations relate specifically to that. Fourth criterion was value over volume. We felt that, interestingly enough, this model is different than many current models in that patients don't get attributed to anything. They have to sign up. They have to agree that they want to receive their care in the home from this team. And in fact, one of the difficulties that Mount Sinai has had in terms of implementing the model in their own environment is making patients feel comfortable with that in some cases, and making physicians who would need to refer to that. So we felt that there is essentially a requirement for quality in this, in that if you aren't delivering good quality care, people aren't going to want to sign up for it, as opposed to this being a more passive enrollment where you're concerned that something might happen to the patient that they're not aware of. However, we were also concerned that because of the pressure to get enough patients enrolled, that there might be some tendencies to convince patients that this was safer than it was. We didn't think that that was a compelling concern, but I would say for everyone's benefit, we looked at this as a payment model that would be available broadly in Medicare. We were not evaluating Mount Sinai or Mount Sinai's implementation of the hospital at home program. We did not have concerns at all about what Mount Sinai was doing. What we were concerned about, though, was if a payment model was available broadly, what potentially unknown entities who sign up for this might do or not do, and making sure that the payment model included enough protections in there for that. And the folks from Mount Sinai were very helpful in terms of helping to articulate how some of those things could be addressed. And as I mentioned before, we felt that there needed to be some method of addressing quality directly in terms of the payment amount. So we felt that on this particular criterion, providing incentives to practitioners to deliver high-quality care, that it met the criterion, and we felt that it did. We felt unanimously that it did so. Fifth criterion was flexibility. We felt that this was strong in terms of flexibility because, as essentially a bundled payment, thank you. As a bundled payment, it gave the provider who received it the flexibility to do whatever it was that the patient needed, rather than being restricted to particular kinds of services. Essentially the same kind of flexibility that a hospital has in being paid a case rate. The one concern would be that if, in fact, the volume of patients was not sufficient to generate the full revenues needed to cover all the costs, that could potentially lead to some restrictions in terms of the services that might otherwise be desirable for patients. We also were somewhat concerned that because there was responsibility for the full post-acute care period, but some patients might need much more expensive services such as a skilled nursing facility, that there really was not the ability to control the patient's choice of that, and so that might limit to some degree flexibility. But we felt that overall that this did provide significant flexibility, and so we felt that it met that criterion. Sixth criterion is ability to be evaluated. As stated, it's to have evaluable goals for quality of care, cost, and any other goals of the PFPM. We felt that this met the criterion. We felt that it could be evaluated. We felt that one could determine whether quality of care was being delivered, and it could be compared to what would have cost to have patients in the hospital. The ease of evaluation and the precision of the evaluation is a different question, simply because trying to identify comparison patient populations when you're picking patients based on clinical criteria, which are not in claims, would be challenging, and that with the small number of patients that might be participating, that reaching statistical significance might be challenging. But we didn't feel that that was any reason not to move forward with a model like this. The issue would simply be trying to do the best evaluation that one could, given the kinds of size, scale, and significance that one could achieve. And this is something that I believe is being struggled with right now because by Mathematica, because they are evaluating the Mount Sinai program, not the payment model, but the program as part of the Healthcare Innovation Awards. Seventh criterion is integration and care coordination, whether this encourages greater integration and care coordination among practitioners and across settings where multiple practitioners or settings are relevant to delivering care to the population treated under the PFPM. We felt this met the criterion. We felt that unanimously because essentially, if all goes well, this is actually reducing the need for coordination because the patient isn't going to one place for their hospitalization and then going someplace else for their post-acute care. They're in the same place being managed and treated by the same provider entity. So in a sense, it's better care coordination. The one concern that we raised was that it could potentially introduce, in cases where it doesn't go well, more transitions, because if the patient needs to be escalated to the hospital and then sent back home, that would create some new transition challenges. But overall, we felt that this was actually improving care coordination, and because the patient was staying in their home in the community, that coordination with their existing physicians, primary care physician, et cetera, would actually be easier than it would be had they been in the hospital. Eighth criterion, patient choice. Again, this is actually stronger in many ways than many other payment models in that it is the patient's choice as to whether to enroll. It is not a passive enrollment passive enrollment on their part. But we did say that it would be important to make sure that the patient was adequately informed about exactly what the services were and what the trade-offs were in terms of the potential risks of being cared for at home, so that only appropriate patients were actually admitted. And we felt and recommended, which the applicant agreed with, that there needed to be some external monitoring of not only adverse events, but also just making sure that the patients who were being admitted were in fact appropriate for that kind of care. The ninth criterion was the only criterion that we felt the proposal did not meet, and we agreed on that unanimously. The concern is that a patient who needs hospital-level care is being treated at home, and there is not a health care professional down the hall 24 hours a day when they are at home. And so that while it may protect the patient from some safety risks that they would have in the hospital, being in a unfamiliar environment, being subject to infection risks, et cetera, it would also subject them to different kinds of safety risks. We felt that there was a lot of things built into the proposal to address that in terms of minimum number of visits, a common set of providers, et cetera. But we did feel, again, based on the inability to know exactly who would be participating in a payment model like this if it was implemented broadly, that there would need to be some kind of external monitoring process. And so the applicant, again, agreed with that, but we felt that this was a sufficiently big change in terms of the proposal as it was submitted that we needed to say the proposal as submitted really didn't meet the criterion. We felt that could be addressed, this could be addressed, but it was not addressed adequately in the proposal that we received. And the final criterion is health information technology. This criterion requires some careful careful reading to determine exactly what the criterion says in order to determine whether one thinks that the proposal meets it or not. The criterion says encourage use of health information technology to inform care. We felt that a program like this and a payment model like this would certainly encourage people to have better HIT in order to be able to deliver coordinated care and to coordinate all the things that were happening to them in the home. We were concerned, which the applicant essentially confirmed in their own circumstances, that the current state of HIT was not exactly up to this. And so the ability to find some off-the-shelf EHR, HIE, HIT solution for this was limited. But one counter to that was it's a small patient population, and so it's not like as if you're managing tens of thousands of patients. It could be tracked manually in the short run. And we felt that this kind of thing was going to be needed to be done more and more often in the future, and that programs like this would, in fact, hopefully encourage HIT vendors to be able to do more of this, although, again, that would depend on the ultimate scale of implementation. So our members of the PRT felt that this met the criterion, and we agreed on that unanimously. So that summarizes my long-winded but hopefully helpful summary. Let me ask Lynn and Rhonda and Kate if I missed anything or they would like to clarify anything that I said to make it clearer or fill in gaps. Rhonda.
So I don't think it was possible for you to have missed anything in that presentation. Thank you very much. That was fantastic. I do want to say a couple of things in positive about this proposal. One, the concept of actually offering a patient and the providers taking care of them the option of treating them at home when they are low on the acuity scale, and not that it's safe and effective, I think is a wonderful thing. We all recognize and we discussed that it would be a low volume of patients, and whether or not the provider group with their hospital partner would find it sufficient for covering the cost of this, that would be another question that had to be asked. But the model itself was something that we actually supported. The questions and concerns about the patient safety piece, we discussed with the applicant and amongst ourselves on the PRT that these were things that could be rectified. They could be effectively addressed. Everything from adverse event reporting, poor outcome reporting, and not just reporting, but actually including in the formal process, the performance improvement, the effort to avoid and to reduce those risks. So I thought it was very well done, and I think that the patient safety piece can be addressed. It just simply wasn't in the original proposal. The subsequent responses were very helpful. I also want to commend them on the part about making sure that the patient choice piece was fully emphasized. The part about making sure that the patient not only had a choice and then had home support, again, highly important to the effectiveness of the program.
I'll just add one other thing that I skipped over, which I think is important. We felt, certainly based on the experience of this applicant with their own program, which was a grant-funded program, and the experience that has been reported from other places where something like this has been done, is that it takes time to get it up and running. So you don't just suddenly like flip the switch and bam, you've got 300 patients being cared for at home. There is inherently some idiosyncrasy to the implementation in different communities based on the kinds of resources that are available in the communities and locations and transportation systems and things like that. So we did feel that having essentially a flat risk standard that would be sort of start from scratch and not change didn't seem to make sense, because there would be startup costs, there would be a learning curve, et cetera. and that particularly given the desire to get more of this in place, that we wouldn't want to deter people from starting because the risks out of the gate were too large. So we also suggested, and again, the applicant did not object to the notion that the risk might be transitioned over time. We didn't try to specify exactly what that time period would be, but not view it as simply being the end state begins at the beginning.
Harold, that was a wonderful summary, and I want to compliment the discipline and the approach that the PRT used for this analysis. I know there was extensive dialogue with the submitters, which we're going to hear from in just a moment. I would like to open the discussion up to the committee members, not to deliberate, but if there are clarifying questions that individual committee members have. I see Bob as one. We'll start that conversation now. Then Kavita and Elizabeth and Bruce.
Very good presentation. Let me do one more of my bio things. In 1999 and 2000, I worked at what was then called HCFA, and one of the demos that was under my responsibility was hospital at home. The Johns Hopkins proposal, I met Bruce Leff at that time. In studying for this, I found a commentary by Bruce in which he referred back to that demo, which happened in Medicare as well as the VA, and then said development of a payment mechanism for hospital at home in the fee-for-service arena using a Medicare demonstration mechanism waiver is pending approval. That was 2009. We have an innovation award that's being evaluated. I guess the question is, this has been around for almost 20 years, and now it's coming to us. Is there a story that we need to know about as to why this either has not succeeded at CMS or that there may be some disabling problems, which we'll get to a little bit later in the payment model? What do we know about the reason that this is still sitting as a proposal and not having been adopted by CMS already? Does the PRT have any insight or knowledge about that, I guess is my question.
I have no particular insight into that other than to say, I guess, that, and I think we should hear from the applicant about that in a few minutes, but as I said just a few moments ago, it is challenging to get something like this up and running, and it is essentially creating a kind of a new system, a new kind of a provider entity, and with a potentially small patient population in some communities, and with the potential threat to the notion that, that the hospital is not the most ideal place in the world. I do think that what is different today is that there is growing recognition that a hospital is not the best place to be for everyone. And so what might have been before sort of an interesting idea becomes more potentially compelling now, but I cannot answer that. I don't know if Rhonda, Len, or anybody else on the committee may have a better answer than that.
I don't have the answer from CMS. I think they would have to provide that themselves, but I know that in our discussions, the concern was the cost of having a diverse, multi-specialty type service available at home. Putting that in place, having people on call, having people on hold, waiting, depending on what the patient needs, would be a little bit of a challenge if you weren't well-resourced and financed to start it up in the first place. That's what I would imagine would be the...
I guess the answer is Bob should have stayed at HCFA long enough to have gotten it into place.
You heard it here first this morning. Kavita?
I just have some clarifying questions. On page 7 of your PRT report for your summary of your rating, you state that multiple studies have demonstrated that the hospital at home care model improves quality and reduces costs. Can you just comment compared to what? Because as you've alluded to some of the and I'm not trying to point to you, Harold, the PRT alluded and referenced, and I've read some of the international studies. There's the Cochrane review. A lot of this is somewhat dated. in that they found a decrease in mortality, but some savings here and there. You already talked about the post-acute savings. Was that reducing cost, is that just kind of a wrap-up comment summarizing, or do you have a sense based on some of the data tables, which I couldn't appreciate, that there could be a reduction in cost despite the limitations compared to something else? And then I had a second question.
Well, I'll start, and again, then Rhonda and Len can fill in. First of all, I think it's important to distinguish what do we mean by cost, right? So spending is really the relevant measure here, and so when we're saying cost, we're talking about spending. And so the notion that has been demonstrated in the studies that's being referred to is that you can take care of these patients at home for a smaller payment than you could for paying for them in the hospital. Now, whether or not it is lower cost is a completely separate and more complicated question, which is what we were raising is, so if these patients didn't have to have a nurse visiting them in the hospital, coming to their bedside very often in the hospital, essentially they might have been viewed as low-cost patients, you know, fully allocated. But it's lower payment for them. And in terms of quality, there are studies showing a number of comparative measures, readmissions, decubitus, other things in which the rates of those for similar patients were lower. And interestingly, one study that was done a few years ago, I think by Bruce Leff, looked at a population of patients in the hospital, classified them as to whether or not they were appropriate for hospital at home services, but did not actually put them into hospital at home services, and then followed by an intervention period in which patients were classified as being eligible and put into hospital at home services. So at least in that particular case, which is somewhat challenging to do, but was done in that particular case, there was a control group of patients who were classified in essentially what was viewed as the same way and then compared them. And so the comparisons that I'm talking about in terms of quality were, in that sense, apples to apples. Other things have been, you know, more difficult to compare in terms of apples to apples, but there's at least that one study that I'm familiar with that did that. And I don't know if Len or Rhonda recall other things, or Tim.
Just from our organization, we have a manuscript under review showing significant cost savings. It's a relatively small sample in our group, but the cost savings are for exactly the reasons that Harold stated were very clear, even in the small sample that we have.
And then just a second question, you reference in the flexibility criterion, I believe, or at least the limitations around small practices. From what you have in the transcripts and kind of the back and forth, it really does seem like it's not feasible for, I just want to clarify, it really does not seem feasible for a non-hospital affiliated group to actually do this, given the resources, intensity, and what's just been acknowledged about what will likely be a small sample size, yet I don't want to say tremendous, but significant infrastructure and time spent to do it. So I just want to clarify, it does not seem realistic, not even a small practice, it doesn't seem realistic for a non-hospital owned or affiliated practice to do this.
Well, let me start, and then Rhonda may want to add to this. I wouldn't agree with that. I think that what I don't think it works for is you wouldn't say to your average primary care practice, how about taking on a few of these patients because, and here's a payment for you to do it. That wouldn't work. But if you look at the staffing associated with this, it's a physician, an NP, and some nurses, and I believe that at least at one point the Presbyterian healthcare model that was going on in New Mexico was essentially using that, but it would be a dedicated practice. Whether or not it had to be part of a hospital or not, I think depends on the level of collaboration that they could get from the hospital, because you have to have a hospital partner, because you have to have the ability to find the patients and be able to admit them if they need to be admitted, but whether they would have to be part of the hospital is a different question. And then I think the other issue is in terms of this risk question, is that if one right out of the bat said you're at risk for paying up to 10% back to Medicare, that would be a big challenge if you didn't have capital. But if you phased it in and if somebody actually built up a reserve, it might well be possible to be able to do that with appropriate risk limits. But I'll see what if Len or Rhonda want to add to that.
No, Kavita, I was going to say, in my humble opinion, it would take multiple small practices with a partnership with a hospital for it to be successful. I think that, though, that may be one way for them to become a more integrated group, informally, without hiring each other. There is some additional information about the cost change on page 4 on the responses.
Elizabeth?
Thank you. I have 2 questions. This may well be beyond the scope of your review, but you talked about sort of setting the rates or prices per DRG. Did you consider at all some of the infrastructure costs that would remain at the hospital and any pricing effect that might then be shifted to other payers? And what the impact could be on total cost of care? You also referenced that this may lend itself to a multi-payer model. Was that part of your consideration when thinking about the multi-payer involvement?
On the first part, yes, we did think about that explicitly. As I mentioned, if you sort of play out the economics of this overall, you would say, well, if I'm taking the lowest cost patients to the hospital out of the hospital. We don't know that in all cases, but let's just assume that if in fact that were the case, then the hospital's average cost per its remaining patients would go up, and if Medicare payment didn't adjust for that, then the hospital would have to make up for that somewhere else. Now, over time, if everybody was doing this, you would say, well, then the DRGs ought to be changed, because in fact, the cost, because a DRG is supposed to in some fashion reflect the cost of the patient care, and if you actually end up with a higher acuity group of patients in a DRG, then the DRG payment would go up. And again, then you'd say, well, you shouldn't be giving them a 5% discount on the new DRG, et cetera. So there's that. Now, your point is, well, if Medicare didn't do anything about that, then the hospital might be encouraged to raise prices for somebody else, and you're absolutely right. On the other hand, this isn't just a Medicare need, and this could in fact be potentially very attractive to, I think, to commercial insurers, who, again, I'm just saying this without evidence or data, but you'd say that a younger, healthier, less comorbid person who simply needs to have home infusions could be a really good deal to send them home. And in fact, a lot of people are looking at that, but right now there is not a clear payment model for that. So it could in fact be very attractive for some commercially insured populations to have the ability to be able to be cared for at home. And if, in fact, you get more and more patients participating in it, then the cost of this goes down. And, so pretty soon, as in the complexity where everything is related to everything else, you get to the conclusion where it's really hard to know how that's all going to play out. So it's there, and it would need to be monitored. But I wouldn't necessarily say, given the volume of patients involved here, that you would suddenly see any legitimate reason for a hospital to suddenly go out and jack up its prices for everybody else. Doesn't mean that they wouldn't, but no legitimate reason based on a program like this.
Thank you. And one different question: are you confident that any sort of regulatory barriers, if there are any, could be addressed either at the federal or state level? Were those considered?
I personally am never convinced that regulatory barriers can be solved until one actually tries to do something and figures out what all the regulatory barriers are, because they always appear, whenever something is actually ready to happen. I think that in this particular case, we have at least one and multiple examples of where this is being done. So it's not like here's an idea that we have that we think would be good, and we can't do it because it's not being paid for, and so if you pay for it, we'll do it. This is a case where people are doing it and can't get the money to sustain it. So I think in that sense, one would hope that the regulatory barriers would be minimal, but whether this starts to, once you create a payment model, whether this starts to implicate fraud and abuse rules and all the stuff that have to be done on that, I think we'd only know that whenever this really started to move down the track for payment.
So can I add, the only thing I can think about is depending on which state is actually going to be doing it, scope of practice, maybe something that has to be just built into it, depending on the state, right?
Thank you. Bruce?
Sorry to do this, but back on the issue of cost. There's a lot of variability within DRGs and the amount of resources that it takes to care for patients. The introduction of MS DRGs helped ameliorate the problem, but didn't eliminate it. So, as you said earlier, the patients who are cared for at home that would have been cared for in the hospital are likely to be the less resource-intense patients. And I've been thinking, well, what could you do to determine how much less resource-intensive? It's very hard to, in the DRG framework, to actually measure the resources that a hospital requires to take care of patients, because it's not required for payment anymore. However, you could measure, let's say, length of stay. You could identify to what extent the removal of a certain group of patients has increased length of stay. I wondered if the proposer proposed that or anything like it to be more precise about the extent to which the patients removed has increased the resource intensity of those that remain in the hospital.
They did not, that I recall. Again, we can ask them when they come up. I think the challenge, again, is that it depends on the circumstances. So if the hospital is bulging at the seams, and its choice is between freeing up some beds or building a new unit, and this would help them do that, that would be very different than if, in fact, the hospital is struggling to survive and this is taking more revenues away from them. I think that the one study that I did review showed that these patients were less intensive on average than the overall patient population, and that's one of the reasons why we suggested that, in fact, simply a 5% on the DRG might not be the appropriate payment, and there could potentially be some way of saying that there would be, if this is a hospital partnership in this, that the hospital gets essentially some of that back to cover its higher average costs through a process like this. But that was not included in the proposal that I recall, anything on that regard.
Bruce, if I could just interject, I think it's really important to think about what this proposal is about, and it's about trying to get people out of the hospital, and really it's the cost of delivering this level of comprehensive coordinated care outside the hospital relative to the payment that's the most relevant. What happens to the hospital's average cost is second order, and it's important, but it's not the focus of the proposal before us, and therefore I think in some ways it's something to be monitored and certainly something to be adjusted for, but you shouldn't hold this proposal accountable for not adjusting for potential changes in hospital costs. It's the non-hospital costs that really matter.
And I would just add, I mean, that's been the case in many other Medicare payments, is that one change got made somewhere that has led to large number of people being treated in different locations, in some cases more expensive, but so I think, and one then has to address it after it happens. So I do think it's kind of that we're trying to deal with some of the first order and second order effects. It's hard when you get to the third order effects to try to figure out what that is.
So my question follows on along the lines of the fee, the payment. 95% of the payment that would have been applied if they were admitted to the hospital. And I guess what I would like to know in the discussions that you had amongst yourselves and potentially with the submitter, do you have a line of sight on 95%? How rational is that? You talked earlier about the upfront cost to get this stood up. Was it 95% to help mitigate some of that lift that would be required to get this off the ground? I'm just curious if there are other insights that you garnered from this discussion around that.
Well, my sense, and again, Len and Rhonda can add into this, my sense is that 5% was there because there needed to be a discount, and 5% was sort of in the order of what discounts were other places. We raised the question about whether or not, given that many studies had shown that the actual cost of in-home services for these folks was maybe as much as 50% below what it is in the hospital. But their point was, we're not just paying for what the patient would have gotten in the hospital, we're also paying for 30 days of post-acute care, we're preventing readmissions, et cetera. And they did provide some data showing that what the costs were overall for the patients. But again, I think our question was, we don't know that 5% is the right amount. It may be a different amount. It ought to be based on some analysis, and it will probably evolve over time. But that's not a fundamental issue in the payment model, right? It just basically says, if we're going to go ahead and do this, let's look at the numbers and see what the right amount should be. And, you know, God bless the applicant that they're actually doing some of this work, so we have some data that we could actually work with on that to be able to look at.
Thank you, Harold. Bob?
I want to try to get a little better idea of sort of the clinical conditions that we're talking about and what happens now with them. So as I'm thinking about the kinds of conditions that I would think might have been and might be amenable to hospital at home, DVTs, deep vein thrombosis, non-life-threatening pulmonary emboli, actually because about 15 years ago, because of low molecular weight heparin and different routes of administration, the standard of care as written up in articles is to just treat these people not on a hospital or home basis, but on an outpatient basis. Cellulitis, other things. I guess the concern I have, or the questions I want to pursue, and also with the Mount Sinai people, is the extent to which current Medicare, traditional Medicare patients are not getting treatment at home because of payment barriers, that you can't get the right personnel. I mean, can you explain to me currently, if a patient has a deep vein thrombosis in Medicare, are they hospitalized because there's no payment mechanism for the needed supervision on an outpatient basis, or are they getting outpatient treatment for their DVT? So that's, I guess, my simple question.
Well, I'll try that, but I do think that one should be directed to Mount Sinai. My sense is some of those people are being treated at home if they have the appropriate supports. Some of them are not because they don't, and they're having to be hospitalized. So in a sense, this program is trying to find kind of a middle group there that wouldn't have gone home today, but doesn't need to be in the hospital, and that there is no option for them. Again, I think you're describing, when I looked at the work in Australia, there seemed to be a lot more, the majority of their patients were cellulitis and DVT patients. There seemed to be a lot more chronic disease exacerbations in the Mount Sinai population. The concern that we had overall was that there would be potentially a risk in terms of trying to get enough patients that somebody who might have gone home today would suddenly be put into the hospital at home program. As many other programs, when you suddenly say there's a new service available, right? And I didn't want to go to the hospital, but oh well, why can't I have that service? Because that's better than the alternative. So I think we should ask them that. I don't know that we have good, clear data on that, and the difficulty is it's very hard without detailed clinical information on the patient and information on their home environment to know exactly what the nature of those populations are that are being hospitalized or not. And Rhonda may have to add.
I was going to say the list of DRGs that they proposed for the patients to be treated at home is in the book on page 7, right? And it's kind of what you would expect. If people are just sick enough for consideration for hospitalization, but not high acuity, as in medically unstable, that they would be eligible. I think we need to distinguish between, are they getting some type of treatment at home, or are they getting what this model proposes, which is a more integrated, comprehensive treatment? I think that's part of the beauty of this proposal, right? As a physician, I can see a Medicare patient, they can have cellulitis, and I can order IV antibiotics or whatever to be delivered, infusion therapy to be done. But then I'd have to also do the other things that they also need to be done, because the patient is not one condition. Typically, my Medicare patients had multiple conditions that also needed to be addressed. So I might need other services. And I think part of this model is that it's more comprehensive, it's multiple specialty, multiple services to take care of them. So that's a little bit different. It's true that an individual physician for that individual patient could prescribe all of these things, but I think what they're talking about is something that is more integrated and that it's a package deal.
And I think that this is addressing something that's coming up in a number of different settings and payment models, is that it depends on the level of home support that the patient has, and which is not a comorbidity, but it significantly affects the cost and approach to care for patients. And so if this enables some patients who have weaker supports at home to be cared for at home, then the traditional, we'll have a home health nurse show up, and exactly who is it that they're training to be able to do, to change the infusion pump.
Thank you, Paul.
Thanks. Just to add on before I ask my question, I think at least the list I saw of their conditions that they actually were in were things like pneumonia, urinary tract infection, COPD, heart failure. And Bob, not to date you and I, but I don't think anyone's admitted for DVT anymore. I remember the days when people were admitted for cardiac cath for 3 days. I mean, I just don't think that really happens. But I think it's more of these more acute infectious illnesses, heart failure, COPD. Anyway, that wasn't my question. My question was just clarifying on the discussion with PRT. So I have a better understanding. On some of the criteria, like 2, it seems like the list of weaknesses is longer than the list of strengths. And I just want to make sure I understand, but yet it met criteria unanimously. I just want to understand in the discussion, was the feeling that you recognize all these weaknesses but felt that they were fixable and nothing was sort of a fatal flaw, and that's why you ended up where you did? Just to get a sense of the discussion amongst the 3.
Well, I'll start and I'll let the others comment, since we all voted on that. But yes, we didn't view, I guess you would say, that one doesn't necessarily weight all the bullets equally. So we in fact felt that it was important for a payment model that seemed to be desirable to try to identify where we thought there were weaknesses so that they could be corrected. But our general conclusion was that all of these things were either correctable or that the significance or severity of it was outweighed by the strengths and positive aspects of the model. That's at least the way I would view it, and I'll let my colleagues say how they felt about it.
I thought that the quality proposal, the metrics that they proposed, was a good start. I just simply wanted more. And so you see some of that. But I also think that part of what they proposed here is relevant also to the patient safety one, where we unanimously agreed that it did not meet. So there was some cross.
I mean, there's just, the strengths are stronger. I mean, that's the bottom line. What we liked about the structure of the model outweighs the second-order amendments that we would suggest you make it before you implement.
And I would just add, that was a carefully considered conclusion. We started in several cases with a more negative draft to sort of kick the tires on it, and concluded that, in fact, that didn't seem to be the right judgment given the balance of these things.
All right, I thought that was a great clarifying discussion, and I want to remind folks that that's the purpose of this particular part of the proposal review, working with the PRTs. We're not deliberating, and we may have brushed up against the fence line, but the DFO didn't speak up, so.